What are the major complications of the postpartum period? Excessive vaginal bleeding, more than 500 milliliters, is a major complication. Called postpartum hemorrhage, it is usually caused by uterine atony, often the result of retained placental fragments. Another major complication is postpartum infection, manifested as fever, profuse and foul-smelling lochia, drainage from the episiotomy, and unusual pain or tenderness in the abdomen or pelvis. Various hemodynamic changes during pregnancy make the postpartum client more susceptible to thrombophlebitis. Signs and symptoms are localized pain, redness, swelling, and an unusual warm spot on the calf. Mastitis or breast infection is another problem, characterized by localized breast pain, redness, tenderness, and swelling. Yet another possibility is urinary tract infection, causing pain and burning with urination. Let's look at these complications in greater detail. Postpartum hemorrhage, or PPH, can quickly become a medical emergency. Losing more than 500 milliliters of blood after vaginal delivery or 1,000 milliliters after cesarean delivery is considered a postpartum hemorrhage. The most common cause is uterine atony, most often from retained placental tissue. Lacerations and coagulopathies are less common causes of PPH. Early or intermediate PPH develops within 24 hours after birth. Late postpartum hemorrhage usually occurs after the client returns home and is most often the result of subinvolution of the uterus, which is the failure of the uterus to return to its pre-pregnancy state. Retained placental fragments and infection also contribute. Risk factors for PPH include hydramnios, multiple gestation, multiparity, prolonged labor, precipitous delivery, delivery of a large infant, and bladder distension. In some cases, vaginal lacerations and hematomas cause severe blood loss. Be aware that some medications used during labor and delivery, such as inhalation anesthesia, are also risk factors for uterine atony. If the woman's labor was induced with oxytocin, she may also be at risk for uterine atony post-delivery. Finally, pregnancy-induced hypertension and inverted uterus are two medical conditions that increase the risk of PPH. What are your assessment findings with postpartum hemorrhage? The most obvious sign is increased bleeding or excessive lochia. The bleeding might be a constant trickle, a steady flow, or a large gush of bright red blood with clots. The client usually saturates more than one perineal pad per hour. The uterus will feel soft or boggy when palpated and may be enlarged. If you suspect a hematoma, find out if the woman has severe, unrelieved rectal or perineal pain. You will also notice tachycardia and hypotension. If you do not intervene, the client can develop hypovolemic shock. What are your interventions for postpartum hemorrhage? When you suspect postpartum hemorrhage, massage the fundus promptly and notify the physician or midwife immediately. Evaluate the client for signs of shock. Monitor vital signs, level of consciousness, and skin color and warmth. Give oxygen and oxytocin as prescribed. Remember, oxytocics are prescribed to help expel retained placental fragments and to contract an atonic uterus. Continue to palpate the uterus frequently for consistency, location, and size, along with assessment of the lochia for color, amount, and presence of large clots. The client's hematocrit and hemoglobin will reflect the severity of blood loss. Inspect the perineum for lacerations, hematomas, or a disrupted episiotomy. If the client has a hematoma, it will probably be quite painful. If it is, apply ice to the perineum for comfort. Palpate her bladder for distension and monitor her urinary output closely. If it falls below 30 milliliters per hour, shock might be imminent, so it is best to use an indwelling catheter rather than a straight catheter for ongoing accurate measurement. If PPH due to retained placental tissue cannot be controlled, surgical intervention might be indicated. If so, maintain IV access and help prepare the client for D&C. Also, be sure to provide support and reassurance to the client and her family. When PPH is resolved and the client is ready for discharge, teach her to report the reappearance of any bright red lochia after the 4th postpartum day. Also instruct her about the signs of infection. Fever over 100.4 degrees Fahrenheit. That's a 38 degrees Celsius. Foul-smelling lochia or flu-like symptoms. If she does have a postpartum infection, she may have a delayed postpartum hemorrhage. Medications that are used to control PPH include IV oxytocin, usually 20 units in 1,000 milliliters of lactated ringers or normal saline solution, given at a rate of 600 milliliters per hour, and methylorganovine or Methergin, IM or IV. The latter is not recommended for women who have high blood pressure, however. Another medication used when more conventional methods do not control PPH is Hemabate. Keep in mind that hypovolemic shock is a very serious potential outcome of PPH. Sometimes bleeding is not immediately visible, but you must suspect occult blood when the client's uterus is becoming distended or is soft and boggy. Remember, PPH can be life-threatening. Uncorrected blood loss results in a loss of consciousness, renal failure, and even death. With retained placental fragments, the client might also develop uterine infection, leading to subinvolution and subsequent hemorrhage. Remember, for postpartum hemorrhage, massage the fundus. Notify the physician or midwife. Administer oxytocics as prescribed, and be ready to prepare the client for D&C. This is a medical emergency. How can you help prevent postpartum hemorrhage? Be aware of your client's risk factors. Encourage voiding to prevent bladder distension. Massage the uterine fundus if it is not firm. And assess for signs of hemorrhage, such as heavy lochia. Prioritize the interventions you'd perform when providing care to this client. Just 6 hours ago, a 29-year-old client, Gravida 3 and Para 3, delivered an infant boy vaginally. About 2 hours after delivery, AG began to bleed steadily, with a total estimated blood loss of 700 milliliters at this time. So far, the client has received 1 unit of blood and is now receiving IV fluids at 150 milliliters per hour. She has a Foley catheter in place. Vital signs at 2 p.m. are blood pressure 100/60, pulse 100, and respirations 12. Hematocrit is 24%. Okay, you would prioritize the interventions in the following way. Number 1, assess uterus for consistency, firmness, and position. Number 2, note amount and character of lochia. Number 3, assess breath sounds. Number 4, monitor urine output. Number 5, take vital signs. And number 6, review lab values. How would you detect postpartum infection? Postpartum infection is any infection of the reproductive tract that develops within 28 days after intrauterine fetal loss or childbirth. The first symptom is usually a fever. Common manifestations of postpartum infection are endometritis, mastitis, episiotomy or incision infection, urinary tract infection, and respiratory infection. Endometritis is an infection of the uterus that usually begins at the placental site and is the most common postpartum infection. Clinical findings associated with postpartum infection are prolonged labor, preterm labor, prolonged rupture of membranes, chorioamnionitis, malnourishment, obesity, anemia, a highly vascular uterine lining, a raw placental implantation site, manual extraction of the placenta, diabetes mellitus, cesarean delivery, epidural anesthesia, hematoma, or contact with an infectious agent, and substance abuse due to associated high behavioral risk. If your client develops an infection, you will first see a fever above 100.4 degrees Fahrenheit. That's a 38 degrees Celsius. After the first 24 hours that last 2 or more successive days, chills and tachycardia. The client may have other flu-like symptoms such as nausea, vomiting, anorexia, fatigue, and headache. Other symptoms of reproductive tract infection are backache, abdominal pain or tenderness, foul-smelling lochia, and purulent drainage. If the uterus does not involute as expected, infection might be the reason. With a wound infection, you'll find erythema, warmth, swelling, tenderness, wound separation, and purulent drainage. Urinary tract infection causes pain, burning, urgency, and frequency of urination. Breast pain with erythema, warmth, and flu-like symptoms indicates mastitis. To confirm infection and identify the causative organism, the physician or midwife might perform vaginal examination and obtain lochia cultures. Blood and urine cultures might also be ordered. An elevated white blood cell count usually indicates infection. However, the white blood cell count is normally as high as 20,000 to 30,000 per cubic millimeter for a short time after labor and delivery in response to inflammation, pain, and stress. What nursing interventions are appropriate? Your interventions will begin with evaluating vital signs, often inspecting the perineum or C-section incision, and assessing lochia and uterine involution. Attend quickly to any postpartum client's complaint of discomfort or pain, such as dysuria, nausea, vomiting, or diarrhea. An intervention that promotes healing in mild cases of local infection is assisting with warm sitz baths. Also, be sure to educate the mother about diet to ensure adequate fluid nutritional intake. You can also provide comfort measures, such as warm blankets for chills, cool compresses, sponge baths, perineal care, and a heating pad. Monitor the client's response to antibiotics and note that clinical signs usually improve within 48 to 72 hours. If your client has endometritis, position her in high Fowlers to promote drainage of lochia and administer oral or topical analgesics, such as anesthetic spray, as prescribed. Remember, the most common postpartum infections are reproductive tract infection, wound infection, urinary tract infection, and mastitis. Other less common complications are sepsis and peritonitis. How does mastitis develop? Mastitis is an infection of the breast, usually involving the ducts and lactiferous glands, typically in one breast. It is most common around 5 to 6 weeks after delivery, but can develop as early as 2 weeks postpartum. The causative organism is usually hemolytic Staphylococcus aureus. The initial lesion is usually on an infected nipple fissure, but as inflammation and edema develop, milk flow is obstructed and the breast becomes engorged. Mastitis is more common among first-time mothers who are breastfeeding. Teach your client about careful hand washing and proper breastfeeding techniques, as this is her best measure of prevention against cracked nipples and subsequent acute mastitis. Risk factors for mastitis are sore or cracked nipples, poor maternal hygiene, poor positioning of the nipple in the infant's mouth, or excessive or vigorous sucking, infrequent breastfeeding due to supplemental formula feedings, maternal fatigue, stress, or other health problems that lower resistance to microorganisms, and dehydration. Signs and symptoms of mastitis are localized warmth, pain, and redness, and enlarged tender axillary lymph nodes. The client may also have flu-like symptoms, fever of 101 degrees Fahrenheit or higher, that's 38.4 degrees Celsius, plus chills, malaise, body aches, and headache. The diagnosis is confirmed with a CBC and drainage cultures. The CBC indicates that an infection exists and cultures identify the organism causing the infection. How will you manage a client with mastitis? Your interventions focus on promoting comfort and maintaining lactation. Discuss the client's expectations of breastfeeding and assess her breastfeeding practices to guide your teaching about proper technique. Include how to position the infant at the breast, how to prepare the nipples for breastfeeding, and how to care for the breasts. Make sure she knows the signs of mastitis before discharge. If she develops mastitis, instruct her to apply warm compresses and encourage frequent feeding on the affected side. She will also feel tired as a result of infection, so encourage her to rest, drink plenty of fluids, and take prescribed analgesics to promote comfort. Antibiotics such as cephalosporins or vancomycin are usually prescribed. Reassure the client that she is not exposing her infant to infection and counsel her to continue breastfeeding. If she is overly concerned, suggest she talk with a lactation consultant. Even with mastitis, lactation is maintained by breastfeeding. Manual expression, or pumping the breasts every 2 to 4 hours to empty them. Teach the mother to empty her breast completely at each feeding to prevent stasis of milk, which can result in an abscess. Also encourage her to drink at least 3,000 milliliters of fluid per day. Reassure her, though, that this is a painful condition, but it should resolve after a few days of antibiotic therapy. And as always, encourage her to complete the full course of antibiotics as prescribed and not to stop earlier just because she's feeling better. Next, let's review what we know about another postpartum complication, thrombophlebitis. Thrombophlebitis is the inflammation of a vessel wall in association with a thrombus. A thrombus is a blood clot that forms inside a blood vessel as a result of injury or inflammation of the vessel wall. Reduced velocity of blood flow, called venous stasis, or hypercoagulability of the blood. Because stasis and hypercoagulability are common in pregnancy, you can easily see how the postpartum client would be at risk for thrombophlebitis. Superficial thrombophlebitis, typically involving the saphenous veins and confined to the lower legs, is the more common type. It usually develops 3 to 4 days after delivery. The client's leg appears reddened, warm, and swollen over the clot area. The leg is tender to the touch, but the clot is firmly attached to the vein. Thrombus formation in the deep femoral, popliteal, and small calf veins is called the deep vein thrombosis, or DVT. It is especially dangerous because of the risk of pulmonary embolism. The clot can break away, forming an embolus carried by the venous circulation. If it occludes the pulmonary artery, it blocks blood flow to the lungs and becomes a life-threatening situation. Risk factors for thrombophlebitis in your postpartum client includes immobility, as in clients who have pregnancy-induced hypertension or a cesarean delivery, anemia, heart disease, varicose veins, diabetes mellitus, smoking, age over 40 years, multiparity, excessive fluid loss, and dehydration, and hydramnios. How will you assess your postpartum client for thrombophlebitis? Traditionally, Homan sign, which is calf pain elicited while dorsiflexing the foot with the knee slightly flexed, was a classic indicator of thrombophlebitis. Although still used in many settings, it has been determined that this sign is nonspecific and not consistently accurate. The preferred diagnostic procedure is duplex ultrasonographic scanning. Doppler blood flow studies may also be informative, and venography can also confirm the presence of a thrombus. Coagulation profiles are helpful in detecting intravascular coagulation. How will you manage a client with thrombophlebitis? Interventions for thrombophlebitis include rest, elevation of the leg, frequent position changes, elastic support hose, moist heat, analgesics for pain, and anticoagulants as prescribed. Caution the client to avoid sharp flexion of the knees and not to rub this affected area. Observe the client frequently and carefully monitor for signs of pulmonary embolism, which are dyspnea, sharp stabbing chest pain, tachypnea, syncope, respiratory arrest, hypotension, tachycardia, diaphoresis, pallor, cyanosis, hemoptysis, and extreme anxiety. A good preventative strategy is early ambulation as soon as possible after delivery. Anticoagulant therapy, either intravenously with heparin or orally with warfarin or Coumadin, is a key aspect of the medical management of thrombophlebitis. Remember that the antidote for heparin is protamine sulfate, and the antidote for warfarin is vitamin K. Anticoagulation therapy is guided by the client's clotting times. Your ongoing assessment includes watching for signs of hemorrhage, such as bruising, petechiae, blood in the urine, bleeding gums, increased vaginal bleeding, tachycardia, and falling blood pressure. Caution the client to avoid taking aspirin or nonsteroidal anti-inflammatory drugs that increase the risk of hemorrhage. Make sure she understands that she cannot walk barefoot. She must brush her teeth gently with a soft toothbrush and use an electric razor, not razor blades, and she should postpone dental procedures that might cause bleeding. Let her know that alcohol decreases the effects of warfarin. Remember, a thrombus becomes an embolism when it dislodges and is carried along the venous circulation. Signs and symptoms of pulmonary embolism include dyspnea, sharp stabbing chest pain, tachypnea, syncope, respiratory arrest, hypotension, tachycardia, diaphoresis, pallor, cyanosis, and extreme anxiety. This is a life-threatening situation, and you must intervene immediately. Now we'll move from physiologic complications to those of a psychological nature. It is estimated that as many as 80% of women experience a blue period sometime during the first 2 postpartum weeks. Although postpartum blues, or baby blues, are usually mild and transient, up to 15% of women experience the more severe symptoms of guilt, failure, loneliness, and low self-esteem, collectively known as postpartum depression. A precise cause of postpartum blues has not been identified, although biochemical, psychological, social, and cultural factors have all been suggested. Physical factors include lower levels of circulating glucocorticoids and the subclinical hypothyroidism sometimes women develop in the early postpartum period. The fatigue of childbirth and the demands of the newborn are among the physical causes. Psychologically, the new mother may feel overwhelmed with parental responsibilities, may experience feelings of loss when she and her newborn are separated, and may feel the lack of attention and support she received during pregnancy. Many psychosocial changes and adaptations take place during the postpartum period, but these changes should not be mistaken for postpartum depression. Reciprocity, the interaction between the mother and the infant, develops simultaneously and is mutually gratifying to both mother and baby. The mother does not fear harming the baby or feel anger towards the baby, as she might with postpartum depression. Signs and symptoms of postpartum depression are similar to those of any depressive state. Your postpartum client may cry easily for no apparent reason, or may feel disappointment or apathy. Besides feeling depressed, she may feel sadness, fatigue, insomnia, headache, anxiety, or anger for no justifiable reason. These feelings peak at around 5 days postpartum and usually subside by about the 10th day. A risk factor for postpartum depression is a high level of anxiety during pregnancy. Although some ambivalence is common in early pregnancy, women at risk for postpartum depression are extremely ambivalent about whether to terminate or to carry out the pregnancy. Other risk factors for postpartum depression are previous postpartum depression, previous problems with premenstrual syndrome, marital discord, poor extended family support, low socioeconomic level, and a history of abuse, neglect, or alcoholism. Be aware that depressive symptoms can interfere with the maternal role attainment. The 4 stages of maternal role attainment are the anticipatory stage, when the mother looks to role models prior to delivery for examples of how to mother. the formal stage, when the child is born and the mother acts as others would have her act. The informal stage, when the mother begins to make her own choices about the infant. And the personal stage is when the mother feels comfortable with her parental role. You must explain to your client how depressive symptoms can interfere with her ability to move through the stages of the maternal role attainment. A variety of postpartum depression assessment scales are available to help identify the condition more precisely. Two examples are Beck's Postpartum Depression Checklist and Edinburgh's Postnatal Depression Scale. Now let's review the classic symptoms. They are depression, sadness, and spontaneous crying. Another is withdrawal, even as the client describes a lack of support from her partner or other family members. Sleep disorders are also common. She might be unable to go back to sleep after feeding her infant. Other indications of postpartum depression are feelings of worthlessness or guilt and difficulty concentrating, fear of the baby or of harming the baby, thoughts of suicide, changes in appetite, either eating too much or too little, plus anything that interferes with normal functioning. Your intervention for clients who have signs of or actual postpartum depression begins with screening for risk factors. Teach your client to expect baby blues and to distinguish them from signs of postpartum depression. Provide strategies to help her feel rested, such as napping when the baby naps or letting someone else do the household chores. Remind her that she needs self-care, like going for a walk or reading a book while another family member cares for the baby. You might suggest planning a date with her partner or going with a friend to see a movie. Be sure to encourage your client to share her feelings with her partner and her family. Depressive symptoms that persist longer than 2 weeks or begin 2 weeks or more after delivery are strong indicators of postpartum depression. When symptoms are severe, the client must contact her primary health care provider. A referral for a mental health assessment and antidepressant therapy might be indicated. Without help, maternal role attainment and maternal-infant bonding are likely to be delayed.